Well, it's 10 o'clock and good morning, everyone. So, hello, my name's Julian Hartley. I'm Chief Executive of NHS Providers. It's great to welcome you all to this webinar on championing transformation, how automating medicines management delivers better and efficient care. We're delighted we've got an introduction to the Automating for Better Care Forum, and we're very pleased this event is supported by BD. So let me introduce you to our fantastic panel. We've got Lord Carter of Coles, great advocate of better ways of working, operational transformation, and particularly in medicines management. We've got Dr. Keith Ridge, CBE, who, of course, known to many of you, ex-Chief Pharmaceutical Officer for NHS England. Great to have you with us, Keith. Warm welcome to Kandar Thakkar, Chief Pharmacist and Clinical Director of Medicines Optimisation at University Hospitals Plymouth NHS Trust. Great to have you with us, Kandar. And Pippa Roberts, Chief Pharmacist, Clinical Director for Medicines Optimisation at Liverpool University Hospitals NHS Foundation Trust, Liverpool Women's and the Walton. So quite a big job, Pippa. So great to have a really excellent panel with us. We're aiming, obviously, to do a bit of presentation and then a chance, really, for a Q&A. Do make use of the Q&A function to make sure that we can use the Q&A box for questions, information sharing, and feedback to the team. That would be really, really helpful. I think it's great that we're meeting at this point, given the scale of the challenge that we're facing across the service. And I'm really interested in where we go with this, because, of course, as NHS providers, we're here to support all of you as trusts in taking forward your transformation journeys, and particularly given the focus on medicines management as a real enabler of higher quality care. We've got, I think, a great opportunity to get into this and really to think about how we can learn from one another, and also think about what best practice looks like and support the necessary change and improvement that we know we all need as we enter what feels like a new era for the NHS. So, without further ado, Patrick, I'm going to hand to you to get us going. So thank you very much.
Thank you, Julian, and good morning, everybody. Thank you for your time. Much appreciated. I want to start really just on where we are. I don't think there's ever been a time since I've been involved in the National Health Service, where the three issues of quality, safety, and value have been pushed into such sharp focus. Each of them are difficult to deal with. But in the world of pharmacy, I'm particularly taken with the opportunity. I should say that, getting pharmacy right is the second biggest spend after staff. It's critical. And why I'm particularly pleased to sort of be speaking today is that in the efficiency work I've done, productivity over time, the most impressive group for me who've delivered time and time again are pharmacists. So I just want to actually pay a tribute to you all, because it's been absolutely tremendous what you've delivered so far. Now, picking up on Julia's point, I hope we're in a new era. There's certainly a new tone about how we're trying to deliver health in this country. And I think the key is how pharmacists continue with their tradition of innovation and carrying things forward. And clearly in the area of medicines management, which in a sense touches everybody. I suspect, if you look at it, it's the largest interaction with patients there is. If you think of the number of prescription, number of scripts, the number of medicines people take each day, and I can speak from experience as an old person, it's one of those things that you are the key to it, really, or the quiet service which does all this. And I think if you look at key things like avoidable deaths and how to streamline work, how to free up time to care on the wards, what we're about to talk about today is really critical. So I'll now hand over to Keith Ridge. But before I do, I'd just like to say thank you again. And I shall be very dull and say thank you at the end. But pharmacists collectively have, in my view, done more than any other single group to transform care in this country. Keith, over to you.
Thanks very much, Patrick. And if I could add my thanks to during my 16 years of being Chief Pharmaceutical Officer to the profession I headed, and what a great job they were doing and continue to do. Can I just have some slides go forward, please? And the one after that. Yeah, thank you. So when Patrick and I, as you would have gathered, have worked together on a number of things over the years, and have been quite successful, I think, in the way Patrick has described, thanks to people on this webinar and the profession in general. But one area which I think where we are needing to go further forward is in the role of technology to speed up and make the use of medicines more productive, as people would say these days, but safer and, of course, more efficient. And there is technology out there that can help us with that. But I guess both of us felt that it needed a bit of a push. And so with the support of BD, we brought together what we've called the Automating for Better Care Forum, which is a group of people, pharmacy, nursing, finance, NHS England, etc., to discuss these sorts of things, to showcase the role of automation, to build the evidence base. And we've come to a conclusion that the sort of health economic case around automation is probably top of the list that needs to be sorted, and then to drive it forward, and to help NHS England and indeed then the NHS in general to drive it forward. Next slide, please. So what's the unmet need? Next slide. So Patrick rightly has already said just what a great job the pharmacy world has been doing across pharmacy, but I guess we're particularly focusing in hospitals at the moment. But as you all know, there are a range of other issues which need to be addressed, and Patrick's mentioned some of them in terms of safety and so forth. But it's not just the safety, it's the money too. You know, we're up to about 20 billion spend on medicines, about 50-50 between primary care and hospitals. And we know that technology could help us in managing both the quality of the use of medicines, but also the spend. Next slide. So some work I did for the former Secretary of State, Jeremy Hunt. We demonstrated I think it was 1,700 deaths per year, but with an overall of a very large number of medication errors, most of which are clinically irrelevant, but some of which clearly are not. And that had an economic cost of about £100 million. There's much more to do. We've done some. Patrick and I have driven forward work over the years to improve inventory, but there's still more to do there. But there's also a need to free up staff time for care, as people will say. And we think this technology can help in that regard. Next slide, please. And the next one. So we're calling this connected medicines management, in that it connects together the various components from prescribing through to supply and through to administration. And indeed, primarily initially within the hospital, but also how this could be expanded to influence procurement, the supply chain, and so forth, plus also linking into primary care. But the focus here at this particular moment is on hospitals. Next slide, please. And we've got a diagram here, which I don't intend to run through, but you might begin to see a little bit more of as the work of the forum proceeds. And indeed, we now have a website which we can send to, the address of which we can send to people at the end. But this is the sort of how we see connected medicines management and the various components of it, and I'm sure you'll all be familiar with it. But one way or another, bringing this all together in one piece of a series of pieces of technology. And my final comment was, let's not forget the data that is generated as a consequence of doing this, and what therefore you could do in terms of providing more efficient care and safer care. I think that is me, and I'm handing over to Pippa, I think.
Keith. Great, thanks for having me. So today I'm going to set out the strategic case for automation in Liverpool. And I think to do that, it's probably quite important to understand our landscape. So if I could take the next slide, please. Great. So in Liverpool, we have 6 NHS hospital trusts within a 5-mile radius, many co-located or connected, and I'm going to demonstrate that in my next slide. We've got multiple digital systems, and that is leading to lots of complexity. And we've got inefficiencies, therefore, in our pathways. Can I take the next slide, please? Okay, so to illustrate what I'm talking about, because if you work particularly in London, you'll know that we have lots of hospitals co-located, so this might not sound quite so unusual. But in Liverpool, we have got North Liverpool campus, which has got, this is the Aintree site, and that's actually got Aintree University Hospital, which is part of the Luft University Hospitals Trust, and we've also got the Walton Centre Foundation Trust, which is a separate statutory body which is joined, if you can see it in the middle, by a link bridge. So the staff actually share facilities, share car parks, but we are 2 separate bodies. If I could take the next slide, please. And then here we are in our beautiful new accommodation in central Liverpool. We've got the Royal Liverpool Hospital on the right, which is joined by a link bridge that you can't see to the new Clatterbridge Cancer Centre, which is a specialist trust which focuses obviously on cancer. So we've got the Walton Centre, which is neurosciences, adjacent to Aintree, and then we've got the Cancer Centre adjacent to the Royal. If I can take the next slide, please. And then in the south of Liverpool, we've got 2 NHS trusts, which don't even have a link bridge between them. They're actually joined by a corridor. We've got the Broad Green Hospital, which is part of the Liverpool University Hospitals Trust, and we've got the Specialist Trust Liverpool Heart and Chest. And actually you morph as you walk along the corridor from one to the other without even noticing that you're in a different building. So for our patients, we've got lots of handoffs as you move across the system, and particularly for patients with multiple comorbidities, this is particularly problematic. If I can take the next slide, please. Okay, so there's a bit of a background here to our organisational setup, which is one of deprivation and poor health outcomes. We're the most deprived area in England, and 57% of our population are actually living in the most deprived quintile nationally. We have in Liverpool a population of 935,000 people, and 21% of our males can expect to live their life in poor health, and the females 24% of their life in poor health, which is a pretty stark statistic. We're the 5th highest nationally for primary care prescribing per weighted 100,000 weighted population, so lots of prescribing, and we've got the highest percentage of patients prescribed 15 or more unique medicines. We're the 3rd highest, and not in a good way, of patients that are receiving 3 or more medicines with an unintended hypertensive effect. And not surprisingly to anybody in the pharmacy space, we therefore see more falls and injuries in our over 65 population. So next slide, please. So what are we doing about it? Well, we're getting our act together in Liverpool. We've got a great new executive team, and we've got a clear focus on outcomes for the population we serve. We're improving our health and wellbeing for staff, and we're collaborating with our partner trusts across the city. We've got the best, most improved trust for place to work, and also for staff to recommend as a place to be treated in the last staff survey. We've seen a reduction of our falls of 42%, an increase in our nutritional assessments of 50%, and a reduction in our pressure sores of 55%. And we've got a med safety improvement programme, which has got 12 key projects, which is seeing a range of improving metrics. So things are on the move, and it's an exciting place to be. Can I have the next slide, please? But this is what we're dealing with. So this slide shows the number of IT systems that we've got in Luft. So this is Luft alone. This isn't the other trust that I've been talking about. And that shows that we've got multiple handoffs between our electronic systems, even within our organisation, let alone across. And a range of these systems are shared with our partner organisations, but some are not. So it's complex. And there's a plan for a citywide EPR, which will bring us all much relief. Can I have the next slide, please? And then in our pharmacy world, if I take a year of pharmacy statistics, there's evident that there's much opportunity for automation. Just some headlines: we've got 2.8 million medicines prescribed last year, 10.4 million medicines administered, and we prepared over 270,000 parenterals in our aseptic units across our hospitals. So we've got lots of opportunity in this space, and all of that is set against a backdrop of innovation in Liverpool. We've got a locally developed web portal which helps our pharmacists prioritise their clinical activity because it's got a clinical prioritisation tool within it. And we've got auto labelling, so technicians spent hours labelling medicines, and the grind of that process is not evident in our Liverpool hospitals because we have auto labelling. And we've got electronic CD processes, which we're working on from order to receipt. So there's lots of innovation happening in Liverpool against which we can build. Can I take the final slide, please? Thank you. So in terms of our drivers in Liverpool and selling that strategic context, this automation agenda absolutely aligns with our trust and citywide collaboration strategy and our desire to improve our health outcomes for the people we serve and the working lives of the people that work within our organisations. So for us, this will involve mitigating the interface risks that I've described, both within Luft, but also across our organisations as our patients move between hospitals. We want to eliminate transcription error. We all know that's the place where errors occur. So our driver is to eliminate transcription errors from our workflows completely. We want to ensure consistency, and automation will help us deliver that. We'll create standardised work, and this will help us deliver consistent care and remove that unwarranted variation that Patrick's talked about. It will help us address some of our workforce challenge. It will minimise the impact of churn, and it will leave people free to do more enriched and advanced roles and work at the top of their licence. One of the key things on everybody's agenda is improving flow, and we can see how connecting medicines management will massively impact on our flow through our organisations, both by reducing length of stay, by getting medicines right early on admission, but also speeding up the discharge process at the tail end of our journey. We know it will deliver cash out and deliver sustainability for our organisations by improving our inventory management, and it's going to strengthen our research. We've got a new school of pharmacy coming in Liverpool, so we will actually be the home to 2 schools of pharmacy, and we're looking forward to working with our universities to strengthen the academic agenda. And finally, as Keith alluded to earlier, it will increase time to care. Free up resources for our staff to spend more time with patients, improve patient experience, and make their working lives more enriched. So for us in Liverpool right now, automation is equal to opportunity. Thank you. I think I'm going to Kandar next.
Thank you, Pippa. Thank you, NHS providers, for having me, and good morning, everyone. So I'm Kandar, the Chief Pharmacist at University Hospitals Plymouth NHS Trust. For those of you who don't know, Plymouth is in the southwest of the country, Britain's ocean city, not to be confused with Portsmouth, which has happened. We've had people turn up for interviews. It's a mere 4 hours drive. But anyway, that's for another time. I'll move on to the crux of my presentation. But before I do that, I think some context is important, as Pippa had done for Liverpool. So we are a large, complex organisation, about 1,100 beds, and we've got lots of change going on at the moment. So we are one of the Future Hospitals programme, so we have a new build commencing very shortly. We are a future EPR EPIC site, which should come online in the next 18 to 24 months. We are an aseptics pathfinder site, and as Pippa just alluded to, we are also a site for a new pharmacy school with the first intake coming this October. And the reason that context is really, really important is because with that context, there is opportunity in terms of strategic drivers to push automation. Can I have the next slide, please? So my presentation is quite a narrow focused, and I've got a vested interest in this as Control Drugs Accountable Officer for our trust, very much trying to implement the vision of digitizing control drugs management and moving towards a fully closed loop system around CDs. However, like with a lot of trust, we have several challenges. So we've got no relevant hardware, no automation. We have an old rower, but nothing more than that. There is no fit-for-purpose software platform that does all of the above. And actually, where you do have some platforms that exist, there are no relevant interfaces or interoperability between these platforms. I've put legislation in there because often that is taken as a barrier. Candidly, the Misuse of Drugs Act isn't aligned with new tech and automation. However, there is lots of best practice. And for those of you in that CDAO role like myself, if you look at the last CQC CD annual report, there is actually a section on tech and automation. So really, the world is changing. Can I have the next slide, please? So what have we got? So what's the progress so far? So we've now got a BD C2 safe. That's the picture on the top. That's actually our safe, except we've got one more tower. So being a large organization, we've got 3 towers there. We've got the new version of the rower, and I mentioned that here in the context of CD management because we've got a lot of our Schedule 4 and 5 CDs in there. And we've now got a BD Pyxis cabinets on 2 of our trial areas. And really the focus of this trial is controlled drugs and how we create that closed loop system. Can I have the next slide, please? I talked about the software platform that sits behind this, which is the BD Inventory Connect. But more importantly, we've now put in the BD Controlled Substances Manager as part of a limited commercial release with BD that allows you to track individual transactions. That bottom right picture is effectively an e-register, and the data that sits in the back is absolutely fantastic in terms of what you can do with it. Can I have the next slide, please? And this is really the crux of this presentation in some ways. You know, what have we learned so far? I'm a firm believer that there is no such thing as plug and play. It doesn't matter what people tell you. And if you're going to be waiting for that perfect plug and play model, it's never going to come. So for me, automation is a journey, and it is really aiming for progress rather than perfection. Often our biggest challenge is resource, time and money. But I think there are opportunities. So, you know, we haven't just got the money to do the stuff I've described. We were successful in getting some money through the NHS First of Type Fund, and we're using that specifically around the right interfaces towards the closed loop system. And as I touched on before, through our limited commercial release, we're working with BD very closely around what good CD management looks like, particularly from a safety and governance perspective. Everybody's touched on and data and research. For me, some of the analytics in the background really drive that operational efficiency. But I think there is something about research as well. Looking at what's available out there, it's not great. And actually, some of the research is very US based. So I think there is something about more of an academic push within the UK, but also the basis of driving sort of business cases forward.
Yeah.
We've learned quite a lot about stakeholder engagement. And, you know, often we think this is about the techies, but actually it's a lot more than that. And sometimes you learn that the hard way. And I guess really to finish off, it's been an interesting journey for us. And often it's not the tech that fails, it's the business transformation and the change processes in the background that actually fail. So getting that stakeholder engagement and the business transformation in the background is really, really important. So I'm really looking forward to getting to that vision, but I think we've made a good start. So that said, I'll hand over to Julian, Keith and Patrick.
Thank you very much, Kandar. Thank you very much, Pippa. Great presentations. Just to say, I think to echo, Patrick, what you said at the start, the kind of can-do attitude, leadership and engagement of pharmacy leaders and colleagues, I think is exemplary across the service. Certainly my own experience of 10 years in Leeds, people like Liz Kay, Andy Aldred, great examples, and Kandar, Pippa, you too. And great to hear about the great work you're doing in Liverpool, Pippa. I think perhaps long overdue in terms of the scale of all of those different organisations. And Kandar, great to hear about the work you're doing in Plymouth. So I'll kick off, if I may, with a question to you both, which is, I think obviously you've embraced the adoption of automated technology and highlighted some of the kind of issues and challenges with it. But when you're in conversations with your other colleagues in different kind of parts of the organization and kind of medicine, nursing, estates, facilities, you know, the whole range of multidisciplinary relationships that you need to have to run an effective organization, what advice would you or do you give them about how to go about adopting automated technology and some of the kind of watch points and challenges, but ultimately kind of opportunities? So any thoughts on that would be great.
Do you want me to go first, Kandar? Okay, so I think for me the people are the most important thing, aren't they? And
Yeah.
I think it was Kandar that said you can't get plug and play. So you've got to bear in mind that people will always be worried. What does it mean for me? What does it mean for my job? So I think we need to be really mindful of getting into workflows, working with the multidisciplinary teams to make sure we make the technology work for them as professions. So yeah, I think that's the main thing. I think, you know, what do they say? Culture eats strategy for breakfast. If you don't engage the people,
that's right,
and you don't make sure you understand what matters to them at the beginning, then you won't deliver, and then actually you'll end up with a really expensive piece of kit that doesn't do what you need it to do. So
yeah.
I think the people are really important.
Yeah. And incidentally, Pippa, that in your presentation, that slide you showed of all of those different systems is, I think, a familiar one for many organizations. So I'm sure you're not on your own there. And really, I think, and sort of good to share the kind of challenges and the scale of the challenge, which underlies the point of why we need to get at this. Thank you. Kandar, any thoughts on that?
Yeah, a couple of things come to mind, Julian. So if we talk about multi-professional, I think therein lies one of the problems. So at risk of sounding slightly contentious, maybe, but not, I suspect, is a lot of medicines and medicines automation is still seen as a pharmacy issue.
Yeah.
And I think doing the work around how do you engage with that multi-professional team and accepting that there's a different benefit for different groups, but actually the underlying benefits to quality and safety for patients actually is across the board. And certainly that stakeholder engagement, getting that executive SRO buy-in, I think is really important. And I think the other thing that comes to mind when you were speaking, Julian, was around being clear on the problem you're trying to solve. And, you know, my presentation was quite narrow focused around controlled drugs because we have some issues around controlled drugs management here, because automation is a very broad brush concept. So what are you trying to solve in your individual organization? Because if you're trying to solve everything, you'll probably solve nothing.
Yeah. No, absolutely. I want to pick you up on that point about exec sponsorship. I was going to actually ask Patrick and Keith about that, but just to say, you are truly the city by the sea. We can hear the seagulls, Kandar, which is nice.
That's what I keep using every second.
So, Patrick, Keith, both of you, I know, and you've both done a huge amount of work engaging directly with trust chairs and CEOs on this agenda. But given the scale of the challenges that the NHS is facing, what kind of key messages would you give to trust chief execs and chairs and boards to prioritise this agenda and really make a difference? And I think obviously crucially that engagement with pharmacy leaders as part of that sort of trust-wide push to develop and improve.
You go first, Patrick? Shall I go first, Patrick?
Yeah, go ahead. Yeah.
Okay, so Kandar is right in that the engagement of the exec team has been variable, I think, over the years from at a local level, and some of that's about the exec team themselves and the other priorities they have, as you say, Julian. Some of it's about the leadership skills of individual chief pharmacists and so forth. But I think when you present to an exec team, when you're dealing with the biggest spend after staff, when you're dealing with the thing which is probably causing one of the biggest levels of harm, and is by and large the thing which you do to patients, either it's some surgery or a medicine, isn't it? So then it feels to me then the amount of time and resource that is used in all of this space, and you just suddenly have this technology which can free up staff, it can make the whole process safer, and you have the potential to take something off the top of what is the biggest spend after staff, then I can't see why any trust board would not be interested in this. So I think that's the sort of case which people have to make at a local level, but from Patrick and I's point of view, trying to drive that through the A4BC form.
Yeah, thanks, Keith. Patrick?
Thanks. I suppose, I don't know about others. Often I feel like, the old adage about a dog watching television. He can see it, but does he get it? Yeah. And I think my experience across the NHS comes very much to the point that I made, that it's how you make the case. I mean, we can sit here, all the critical points about workflow, safety, all those things are critical, but pharmacy is in a very competitive landscape for resources. And for me, the key to come out of this is how do we make, and I think the narrow focus is a very good point. You have to build up how to make the case. What are the steps for making the case? I don't think any acute provider or anything is going to have sufficient money to do everything. So the question is, how do we prioritize? And above all, how do we make the argument? Julian and Keith, we've been around a long time where often assertion appears to outweigh evidence.
Yeah.
And I think those times are changing, and I think we're much more to evidence. I think one of the critical things for this is how do we build exemplars which are backed up by good research and verification of that, and just to make sure that these things are out there for people to do and start proving it, find a number of trusts where we can prove it. The capability at trust level in many pharmacy departments is there. The question then is turning that into something we can share with colleagues and then using that to make the argument to senior management. So I think at the national level, I just end with talking about leadership. The reason pharmacy worked very well in the time I was reviewing these things is Keith was a great national leader. David's a great national leader. It's getting the national leadership and then working down, but with very, very hard evidence to back it up.
Yeah, great.
And by the way, Julian, solving the capital issue, I think is going to be
no,
you might
absolutely.
want to say something about that.
Absolutely right. And I mean, just briefly on that, for all colleagues, I think as NHS providers, we're pushing hard the view that we need a national NHS infrastructure program that looks at how to get more investment into NHS capital, which we know enables automation, productivity, better ways of working, and frankly, just better environments for patients. And Kandar, you mentioned you're part of the New Hospitals Programme. I'm sure you've experienced some frustrations along the way about the speed at which that's moving. So much to do there. And I think encouraging that we're hearing about the Treasury talking about rewiring for growth. And I think the NHS can be part of that in terms of finding investment from other sources than just the ones traditionally we've used, given the shortage of that and the pace of change. So I'm going to actually sign off and I think leave you to the questions, because Joe, Roberta, I think we're getting some questions in the chat now for our excellent panelists. But that's been a great sort of entry point into the issues. And I think we'll make sure that we continue to support this work as providers. And can I just say a massive thank you to the panel, and really appreciate the thought, energy and work that's going into this. And we'll continue to stay close to the journeys that you're all on with automation. So thanks, guys. And over to you, Joe, Roberta, and the questions. Thank you. See you later.
Thanks, Julian. And Patrick, I suggest there are 2 or 3 questions that have been put in. If we start with those, I think that would be a good idea. So the first one is about the nursing community, and do we think that automation will help them, and how we should bring them on board? So Patrick, do you want to say something about how we should bring them on board and how we can help them? And then perhaps I'll ask Pippa as well.
Thanks, Keith. And I think it's to Kandar's point that we do have a lot of siloing still, don't we? I mean, we're all aware of it. And I think we were talking about this last week, how we bring nursing into this is really critical, because, you know, at every level, they are the front line for this. So I would think as part of this, Keith, it's absolutely critical that we engage. And in fact, I think work now is already underway to engage with the nursing profession to see the best way to do it. And I think probably it's one of the most exciting things, because I think, you know, there are many calls on nursing time, and it's probably, I might say this, perhaps pharmacists, but more particularly nurses, our scarcest resource. So how do we actually free up time? How do we make it easy for them? How it integrates? It's going to be quite interesting to see kind of about how it works with Epic, how the workflow tools come through. You might want to come in and say something about what you saw in the demos that led to the decision to install it. But to answer simply, it's absolutely critical that there's a strong engagement with nursing, and they feel above all that they've got some ownership in the solutions that are proposed.
Thanks, Patrick. And yeah, the forum, the RCN around the table at the forum, but we, as you rightly say, we are looking to engage nursing much more. Pippa, do you want to just say something about the nursing side of things?
Yeah, I think I'd echo all of that, really. I think on the shop floor we need to start in a way with systems that make it easier for the nursing staff, because they're absolutely frantic. And what we tend to do is put things in that make it worse. So we need to really get the engagement at all levels of the organisation, get the executive nursing leadership on board. But I guess then it's about creating a coalition of champions, making it easier for them, and then they will advocate. And you know, my experience is, if you do something that makes a nurse's life easier, then it spreads like wildfire. Do something that makes it more difficult, and then it just creates a whole world of pain and resistance, and things don't go according to plan. So I think for me, that's what we need to do. And we need to find, I know in Liverpool, we're very lucky that we've got a team in pharmacy that can do programming work, and they have, you know, they've built a range of infrastructure that supports the nurses to do their job in an easier and more streamlined way. So that makes things, you know, that makes further change more welcomed in a slightly different way. So I think it's starting off small, engaging, and then you know, I think nursing staff are just keen to do the right thing by their patients, so they do get on board. Yeah,
I agree. And I think also the sort of the additional security, I think, is, you know, with the various tragedies that we know about in the past, then, you know, the additional security does feel to me an important feature as well. Kandar, there's a question here about ICSs, and do you envisage in the long term that the automation will not just roll out across the hospital, but be connected across a system into primary care? Say something about that.
Yeah, I mean, I think so. I think that there is something about the maturity level of ICSs. There's a bigger fish to fry in terms of that initial, I guess, getting together and other priorities. But I think in the medium to long term, perhaps, and I'd probably say that for two reasons. Our biggest issues are money and people. And doing it across systems may allow us to get scale in terms of investment. And in terms of people, we are not far. I mean, some areas are doing this already, where we are sharing workforce. And if you're doing things at scale, you may be able to use the workforce better in different areas because you have similar automation. So I think it's going to take some time, but I certainly see that as part of the future, Keith, in my view.
I agree. And Pippa, I know from your previous job, you were very connected into the broader system. Do you see that happening in Liverpool as well?
I think in Liverpool it'll be different, but absolutely it's already happening. So in where I worked previously, as you know, Keith, I worked across the system in a system-wide role, where in Liverpool, the ICS leadership and I are literally hand in glove constantly in conversation about how we improve our pathways across the system. So not all employed in one organisation, but with the same effect in a way, just through regular conversation and dialogue about how do we streamline those pathways and reduce the interfaces. So yeah, absolutely. I mean, yeah, it's one of the biggest areas of problem, isn't it, when we move our patients, and particularly in Liverpool, because we're not only moving them between primary and secondary care, we're moving them between all those organisations I described. So, coming closer together with one EPR, with one information exchange, with access for primary care colleagues into the hospital systems, and independent of employer is the way that I see that going, rather than needing to employ everybody in one organisation.
Okay. There's a question about conflicting priorities and how people can persuade an organisation to invest. And I think part of that inevitably is about finance. Patrick, do you just want to sort of say how you think we can, A, get the finance professionals properly interested in this, and secondly, persuade them at national level, let alone at a local level, to invest in this technology?
Yes, I mean, I suppose we should start by, Julian touched on it. I mean, this is about capital. It's about capital, but also the financing change, which is difficult. You often have double running costs. You have things like that if you're to get there. And I think at the moment we're uncertain about what the financing envelope is going to be. Probably it's unwise to speculate, but I think Julian's onto something about the Treasury looking at different ways of doing it. But Keith, I return to this point that the three issues that we need to convince people about, are the issues of quality, safety, and value. And I think we can only do that if we have a really, really good series of exemplars. I sat in the Treasury for 10 years, and the number of arguments that came forward, I'd say arguments, cases, I think we call them, people looking for money with what I regarded often as facetious arguments, was not good enough. And I think to carry out, we've got to do it at every level. National leadership has to do its role, but the key is, for me, down in the acute hospitals, and I know they're there, finding these exemplars and presenting them in a highly rational, professional manner. That to me is going to be the key to this, because there's going to be tons of money tons of people out there sort of sticking their hands up for money. There's two key things: a strong example, plus a continually pointing out that pharmacists have delivered. That's the key to me, that if you're looking to invest behind a group of competent people who will deliver, have a national record of delivery, I can tell you to local delivery triumphs in various things, but I cannot, apart from pharmacy, take you to a national group that has delivered. And I think how we get that out there is really important. Strong advocacy at the top, and built on strong evidence from local provision. Sorry, it's a bit of a long answer, but it's that's a critical bit.
That's helpful. And so, Kanda, in reality, how did you do it with the Director of Finance?
Thanks, Keith. I mean, I'm just going to go back to what Patrick has said, and I touched on my presentation. We haven't had huge investment because there is no money. So I think forging partnerships, understanding where there is an opportunity to get some national capital, and perhaps using other innovative routes internally to get something small and focused going, to be able to produce some real world, to use Patrick's word, not facetious data, but real world data that shows the benefits, and then trying to convert that into a more scaled up case, which is what we're doing at the moment, is perhaps the way forward. I've certainly had very positive initial noises, but that's very much based on getting some real world data, not academic literature, which may not even be based in the UK and based on very theoretical arguments. So it's always been, for me, a small focus, a defined focus, get some real data and use that to scale up.
As part of the, as part of the forum work, we've recently undertaken a literature review, which will be published on the website, which shows the sort of strengths and weaknesses, and indeed, where the priority should be. And we think for research, and we think that's largely around health economics, but also in terms of how to implementation science type of work. That feels like is where the priorities around the research is. Patrick, sorry, you're going to say something.
No, I think it is back to this point. Also, it's about the implementation. You might get the capital for a good kit, but actually it's the implementation. And back to the question about our nursing colleagues, it's how you involve people in this. It's that trying to share the best practice and just getting it out there and being realistic about time. But I think the point really for me is that it doesn't happen immediately. It's got to be that relentless focus and returning to really the concept of operational excellence. Operational excellence is the foundation for it, and pharmacy is probably the best position to prove that. And I think one should have a sort of timeline here that says, what can we prove by the spring of 25, and then strategically, where does it go from there? How does it look in the lifetime of this Parliament? When might money be available? And a concerted thought, Keith, really about how we make that argument nationally. I'm sure we can do it locally.
Yeah. So Pippa, you're on the perhaps thinking about that huge site, and how are you sort of discussing with the Director of Finance at Liverpool what's going to have to happen?
Yeah, I think there's a few things, and for me is obviously the Director of Finance is interested in the money, the cash out, but there's also a big amount of cost avoidance when you look at errors, and there's the Shaw model that looks at cost avoidance figures for medication errors of different sort of serious stage of severity. So I think it's bringing all of that together for the DOF, but I think it's also talking about flow for the ops director, patients in the corridor, and it's talking about releasing nursing time for patient experience and self-medication and all that other good stuff that sits in the nursing agenda, reducing the medication errors. So I do think the finance director is important, but equally it's trying to hit all, in a unitary kind of board arena. You need to tick the boxes, I guess, of all of the execs and make sure it goes to that point, really. And just as everybody said, I think research is the key to that. So looking at how we prove the case will be critical if we're going to roll it out large scale.
Okay, there's a question here about other countries and any learnings. If I say something about that, and I guess people look to the US, but let's remember that that's a very different healthcare system, who use, in pharmacy terms, use unit dose, which we don't. And they did that for a reason over the last 40 years, or in fact 50 years. And that was about charge capture for individual drugs and individual patients, as well as reducing the risk of diversion in a system which is insurance-based, let's call it that. So I think the drivers are very different in the US, and rightly the data in the US is sometimes applicable, but sometimes not to the UK. So there was also a question here about data. So the data on medication errors, will that sort of, would that be available? Do you anticipate a positive impact on safety? Whilst at the same time optimizing nursing resource? That's what the questioner asked. So, Candace, do you want to say something about errors and what you're sort of seeing at the moment as a consequence of the technology?
Yeah, so thanks, Keith. It's early days for us, but I might draw on your last question, and I've had the pleasure of being a chief pharmacist out in the Middle East, and you're right in that it's different. It was unit dose, but we had the money to automate the entire hospital, and the reason I'm putting this in for context and not answering your question, which I will in a second, is because to get those real benefits around dropping medication errors, you almost need the full works, if you like, the full closed loop system. I think what we need to accept in the UK, and if I look at our own example in Plymouth, is that you might see different benefits at different parts of the journey. So putting in automated cabinets and putting in robotics, you may reduce your amount of expired stock, you may improve your stock holding, you will improve your accuracy of dispensing or administration. But to get the real reduction in medication errors that's published in some of the literature, particularly from the US, you need to really move towards that closed loop system we don't have yet. I think we've got tons and tons of very good quality baseline data, locally, nationally, regionally. I would expect those medication errors to reduce, but a little bit further down that journey, not immediately. And I think in some ways that's where lies the challenge, because from a quality safety perspective, you're not going to show a massive dramatic reduction in errors straight away. You will probably have different benefits initially and have to accept that you have to do that to get to the further downstream benefits. So that's my view anyway.
Okay. And Pippa, from a not just from an error point of view, but what are you hoping for in terms of freeing up staff? And I'm thinking not just nursing, but with pharmacist prescribers coming along for everybody in 2026, at least all new pharmacists. I would imagine that they will be wanting, and we will want them to spend much more time on clinical duties. So what are you hoping for around that?
So absolutely, free up time to improve the patient experience. I think there's loads in the literature, isn't there, about it's not what's the matter with me, but what matters to me. And if we don't actually have the time to have those conversations with our patients, we can prescribe and administer lots of medicines that the patient never takes. So for me, this is absolutely critical to free up pharmacy time to prescribe and have those conversations with patients, so the shared decision making isn't something that's in a piece of nice guidance, but actually happens in practice. And I think we've made big strides in that space, but automation will revolutionize that for pharmacy, I think. In Liverpool, we've got automated labeling. So the portal drives the labeling from the EPMA system. So we don't have hordes of people labeling prescriptions every day. And that has freed technical time to do all the tasks. So I think it'll just expand. I think, to be honest, the world's our oyster with automation. If we get it right, then it is, as I said in my presentation, a massive opportunity.
There's a question here about overstocking of medication, and Patrick will remember we went through a process as part of his efficiency work to reduce stock holding in hospital pharmacies, and I think quite successfully. Is that still a problem, or has it come back as a problem, overstocking of medication in a hospital? Pippa, do you want to carry on that?
I think lots of things that were on a journey before the pandemic have reversed a little bit, and I think the the anxiety around medicine shortages is probably driving increased stock holding, and yeah, and on the wards as well, I think. So you know, for me, I'm thinking about where I was to compared to where I am now. You know, we need to be releasing staff to use them in the best way. We need to automate the way we do our traditional pharmacy top up. We need to do it more frequently, and we need to have less lead time on the wards, less lead time in the pharmacy. But I think, yeah, it probably, I would say, looking at where we are in Liverpool, that's a piece of work that we are in the process of doing in preparation for our automation. And with our automation, we're hoping to take that a step further.
Yeah. And Candar, have you seen something similar, an increase in stock holding, and now you've got the technology, or at least some of it helping?
No, I echo everything Pippa said. So, you know, when you look at, I mean, this is obviously a very heavily and nationally benchmarked area due to some of the work Keith, yourself and Patrick have done. And, you know, we are quite aligned with national benchmarking. So we haven't seen an overall increase in stock holding. But my reflection on there, and this goes back to Pippa's point, is we've gained a lot of efficiency in non-shortage areas. But unfortunately, that's been mitigated in a negative way by some of the areas where shortages have driven an increased stock holding. So your overall figure looks like it's smack on in the middle. But I think if we had less of an issue with shortages, I'd see that figure coming down. So yeah. Well,
thanks everybody. We've come out to the last few minutes of the webinar. I wonder, Patrick, if you've got some sort of closing thoughts and advice for people.
Well, I think the closing advice is keep doing the good work you're doing, first of all. I think it's critical because this is going to be, you know, we think, don't we, how many times have we thought we're at a crossroads? It's always a bit of a myth, but this is a really critical time, and the role pharmacists play in determining the future is really critical. Keith, I suppose I've got a question in a sense as well, is just improving the case, which I'm very dull about banging on about, but unless we get pharmacy up there with elegant, well-structured arguments, do we have any data about compensation paid to people as a result of medication errors? And I just wonder if we could bring that into the debate and etc.
So there is some. There's both individual data, but also the work we did for Jeremy Hunt with the a few years ago now. The sort of economic cost was about 100 million for in terms of the level of medication error. So
it sounds very low given the overall bill of general error, but okay, that's very helpful. I think just to say that, to me, the critical thing is identifying professionally what we believe the technologies are, and then trying to, in a sense, create a hierarchy of argument in the sense of which we want to push first. I mean, I think it's Candar's point, you can't do everything, and there will never be enough. So what do we prioritize? How do we make the case? And how do we engage? And particularly, I suppose two groups for me are critical in this. It's nursing and it's directors of finance. You know, they're the two people. You know, you've got to get the front end right, and we've got to prove it to our colleagues in finance.
Yeah, so I couldn't agree more. I think it feels like Pippa and Candar are on the road to doing exactly that, which is great. And there, of course, there are others who have done that too, particularly with centralized robotics. But the case for the for cabinets and then connecting it all together in amongst that enormous diagram which Pippa shows in terms of the interoperability challenges, I do think that's the next step, is to rather than what's been by and large a bit of a piecemeal approach to the deployment of wall-based technology, to get that sort of much more up there in the way that, you know, you're describing, with the right people, and then importantly to make a big effort to connect it all together, because I think that's when, you know, prescribing with administration, with with the supply chain ultimately. That's, I think, where we're going to see the enormous gains that this technology can bring.
Yeah. And
So,
I think come in there, I think the critical thing is to understand the so-called single view of the patient. You know, as we move to integrated care, you know, we're talking about stuff hopefully moving out of acute hospitals. That's the stated aim of this government and many others. How do we see the single view of the patient? How does the medication records travel? How do we see all this fitting together? It's going to be absolutely critical in the coming years. You know, and I think that's something we need to understand at every level, how it sort of plugs in. Yeah.
I agree. So I think we're just about out of time. So thank you to Patrick, to Pippa, and to Candarp, and to Julian, and to NHS providers for hosting this, and indeed for BD for sponsoring it. With the forum, we're trying to make it as independent as possible, and I hope that over the next few months you'll be hearing a lot more about the forum, and we'll try and help you along this journey. So thank you very much, everybody, and I hope you found that helpful.
Thank you, Keith. Have a good day, everybody.
Thank you all.